Okay, thank you. And we're a little bit early, and Michael Nolan, I don't think is connected yet. So I'm going to do some introductory slides, and I've sent a message for him to get connected as soon as he can. And if we're still ahead of schedule before he connects, I'll try to do some of his slides as well.
Yeah.
So thanks for having me here. I'm Gary Wingrove, certified community paramedic and fellow of the American College of Paramedic Executives. And I wanted to introduce you to the concept of community paramedicine. It's actually fairly basic. It's taking an existing healthcare provider that has a very, very broad scope of practice and using that scope of practice in a different way. So an example of the way we do that, a traditional paramedic may respond to an emergency call for assistance and need to give a patient some seizure control using a medication delivered by an injection. And in their community paramedic role, they would use that same skill of giving an injection, but it might be vaccination that they're giving instead of seizure control medication. Paramedics commonly start intravenous lines and mix drugs into them, often drugs that affect the heart rate or strength of contraction of the heart. In a community paramedic role, the paramedic would use that same skill of starting an IV and mixing a medication, but in their community paramedic role, it would be an antibiotic that they would be administering instead of a medication that would control the heart rate. So it's a very broad scope of practice. There are existing practitioners, and in many rural areas, because the run volume is low, the paramedics have time when they're not attending to emergencies to spend time with other kinds of patients. So Chief Nolan's important to this presentation because his agency actually has a palliative care component to their community paramedic program. And it'd be best if he can speak on that, but I'll catch up if he's not connected. We have had 4 countries marching down this community paramedic pathway together since 2005. We've conducted 18 meetings over 15 years. Our first meeting was in Halifax in July 2005, and the International Roundtable on Community Paramedicine has been flourishing since. The countries that dominate our meetings are the United States, Canada, Australasia, and the United Kingdom, although we have had participation from Israel, Germany, and many other places. But we're all sort of marching down a pathway together, learning from each other, and conducting meetings on an annual basis. We rotate those meetings between the 4 countries. Our meeting in 2020 was scheduled to be held in England in March. And of course, we couldn't do that because of COVID. So I'm also not quite sure what our next one will be, but we're hoping travel restrictions might be lifted and it may be possible to do that in England in 2021. So I wanted to give you a little example of what the 4 countries look like. They're very different. In Australia, there are 8 paramedic services. They cover a population of about 24 million. And so it's about 3 million people per agency that are being served. In the United Kingdom, there are 13 paramedic services. They cover 65 million people, about 5 million people per agency. In Canada, there are 119 paramedic services covering about 36 million people, so 301,000 per agency. In the United States, we have 19,000 agencies covering 321 million people, or about 20,000 people served per agency. Let me see, I'm not advancing. There we go. And so in Australia, I mentioned there are 8 agencies. Those are delivered by 6 state operated or contracted services, and then 2 territorial. so a total of 8. In the United Kingdom, there are 4 countries involved, and they have 13 ambulance services between them. In Canada, 7 of the provinces have a provincial-wide ambulance service, and then they have one each. And then there are 112 agencies among the remaining provinces and territories.
So, sir,
And
Gary,
yes,
sorry, sorry to interrupt you. So, we can hear some background TV voice or something. Can you stop it?
okay, I think it's my puppy. I'll give me 1 second, I'll be right back.
Yeah.
Okay, is that better?
Yeah.
Okay, great. And again, in the United States, we have 19,000 ambulance services, 300 just in Minnesota, where I'm from, and most of those are volunteer ambulance services. So the community paramedic has been on a pathway. We developed a curriculum in 2007. Version 1 of the curriculum came out. We pilot tested it in Minnesota with a group of experienced paramedics. Then we created a second version, pilot tested it in Colorado, and then we developed a third version, which is the current version. And we release the community paramedic curriculum to any accredited college or university in the world. And it's free of charge. We'll have version 4 of the curriculum ready early next year. It won't be free of charge to the colleges anymore because we've lost our government funding to sustain that project. But it will be available. There'll be a licensing fee attached to it. So that program is standardized, and we have paramedics from all over the world that have been through that program. We have also established a degree pathway of community paramedics, and this is sort of what it looks like. The primary care technician and community paramedic technician are what I would call a short course, and they're intended, the primary care technician is for paramedics that just have basic skills. The community paramedic technician is for advanced paramedics, but those 2 curriculum are mainly designed to make paramedics good decision makers about not transporting patients. And then when we move to the next level, the community paramedic clinician program is intended to be part of a bachelor's degree. The community paramedic practitioner program, I'm sorry, an associate's degree on that one. The practitioner program, a bachelor's degree, the advanced practitioner, a master's degree, and community paramedic consultant, PhD level program. So we have some of those in place. We don't have students in the PhD program yet, but we have some of those functioning in various parts of the world. One of the advantages that we've had in community paramedicine and the 4 countries working together is we've been able to also address some other topic areas. And we formed the Global Paramedic Leadership Alliance among the 4 associations that host the IRCP meetings and the IRCP itself. So we're doing some work in position statements and standard setting. And one of the big issues that we have right now in paramedic service is mental well-being and suicide. So we're concentrating some effort globally on addressing those internally with paramedic services. So I wanted to just show you some numbers from a paramedic service. This happens to be Chief Nolan's service. I want to sort of walk you through what happens when community paramedicine is introduced in a community. So in Chief Nolan's area, they serve 100,000 people. In 2016, they had 15,000 community paramedic visits. And in 2016, they had 11,000 a 911 here in North America patients. It might be 999 or 000 or something else where you are. But what I wanted to point out is when a community paramedic service is established, the number of scheduled or urgent visits by a single community paramedic to a patient quickly eclipses the number of emergency calls that are come in. One of our goals is to reduce the number of emergency contacts and also reduce the number of patients that are taken to hospitals. In his program in 2016, they had 700 enrolled patients, 160 paramedics delivering emergency care, 26 paramedics doing those 15,000 visits to patients in their home on a scheduled or non-emergent basis. 5 of those working every single day. And then they have achieved a savings of 12%. They have had a 5% reduction in the number of emergency calls that they get, and then another 7%. So it's a total of 12% call reduction that they have had. One of the hallmarks of community paramedicine is that it be integrated into other health systems of care, not simply a referral process. So if a community paramedic program, we're going to partner with an agency that delivers palliative care, that would be a tight partnership, not just paramedics referring patients to palliative care and palliative care referring patients to community paramedics. So for example, if we're part of a program with cardiologists that we monitor their patients after having had open heart surgery, the community paramedic needs to be part of the cardiologist care team. Ambulance really doesn't apply there. They need to use the same standard order sets, have regular communication, progress updates. One of the things that we've discovered is really beneficial is to make sure everybody's on the same electronic health record system so that notes can be directly entered into the chart that the clinic and the hospital are going to see. But equally important, the community paramedic can see the patient's prior visits, their medication list, their list of allergies, schedule physical therapy appointments, whatever that might be. So oftentimes we're working on 2 different electronic medical records. That's something we need to change. We have one for our emergency call outs, and then we have a separate one that we're using in a community paramedic program. So this is really what that integration should look like. The community paramedic, if doing palliative care consultation, would need to be part of that palliative care team and make sure everybody's using the same set of protocols for patient care delivery, and make sure that that's all consistent. Give me 1 second. That's my puppy again. Okay, I don't like to do that, but I locked him outside. So that's what integration looks like. We also have some things that are contemporary that are going on that I wanted to tell you about. One is standards. The Canadian Standards Association has a framework for community paramedic programs. It's an ANSI standard, so any of you that are in a country that uses ANSI, the standard is available to you. It's also available on the Canadian Standards Association website. Here is sort of what community paramedicine looks like. It's sort of a busy circle. But it's a really descriptive of what community paramedics do. 2 types of models have emerged. One model surrounds the emergency call and trying to make sure that the patient that calls an emergency line gets the right care in the right place at the right time. So that might be treating them at home and leaving them there. That might be taking them somewhere other than an emergency department, or it might be taking them to the emergency department. The other model is a model that's integrated in primary specialty and public health, and again, part of those healthcare teams as well as paramedic team. So they have two different skill sets. The paramedics that are working on the emergency calls need to be safe decision makers for disposition. Oftentimes that will include telemedicine, where the paramedic will consult and the physician can see the patient, ask the patient questions directly, and help make that decision. On the integration side, those are paramedics with an education level that enables them to integrate and be part of a decision-making care team. We have accreditation coming for colleges that operate community paramedic programs. I believe that will be ready in January for starting site reviews. And so that's all I had. I think Mike has joined now. Is that correct? Mike, are you on?
So yeah.
You are? Okay. Do you want me to display your slides, or do you want to do slide sharing from your side?
So I think Professor Michael is not yet joined, I think. Professor
Okay.
Gary, I think he is not yet joined. Your co-presenter, right?
I'm sorry, what was that?
I think Professor Mike is not yet joined.
He is not. Okay.
No.
All right. Well, let me, if you would just monitor to see when he comes on, I can start with his, and I can do the early ones fairly easy. It's when it gets into the specifics of the program where it'll be difficult for me. So Mike's the chief of the County of Renfrew Paramedic Service that is located in Ontario, Canada. That's just north of Ottawa. Here's a little picture of the area of Renfrew County and the area that's served by that paramedic service. And these are some response zones that they have. These are where ambulances are located and will respond to requests that come in through the emergency system. And here's a graphic that displays the time that it usually takes for them to respond into these areas. You can see that in the more urban parts of the county, the response times are relatively short. And as you get out into the distant part of the county, the response times are longer, and that's simply a factor of time and distance. They have 5 zones assigned for their community paramedics. So they're each of the 5 FTEs that I mentioned earlier is located and is covering one of these 5 districts every day. In Canada, there are 2 main levels of paramedic: primary care paramedic and advanced care paramedic. Then they also have a critical care paramedic category that isn't in this graphic. Then they also have community paramedic, and Canada uses a model of medical delegation. It's a little bit different in the United States. In the United States, physicians are responsible for the care that's delivered by paramedics and making sure the orders that they follow are written. Canada, Australia, the United Kingdom all have models where paramedics are independent medical practitioners, and physicians and others provide advice and counsel, but the individual paramedics are responsible for the things that they do. So this is a graphic that shows the different programs that community paramedic programs that Renfrew County operates. The first one is a response to a request or a referral that they might get. where an assessment is done, treatment is provided, they're diverted to the appropriate place to receive their ongoing care. They may make referrals to social service or other agencies, and then they have their long-term and palliative care, and this also helps them provide surge capacity because the community paramedics are also paramedics, and in the event of a crash with a bus and lots of patients, they can be part of the back part of that emergency team. They have an assess and refer program. They use a risk assessment tool in the hospitals for falls and for a risk of readmission. They try to do early detection and intervention with those. Televideo assessment is an option. Usually that would be from the community paramedic to the patient in their system. They try to predict the patients, again, through scoring that have a high risk of readmission or an adverse event happening at home. They do health surveillance. There's a healthy telemonitoring program that Renfrew County operates, where patients are provided with a number of electronically connected tools, such as a scale, a glucometer, a blood pressure cuff, a pulse oximeter. Those are the information that comes from those devices is collated and sent electronically, and there are parameters that are set for each patient. And when the patient falls out of their parameters on any time that they're doing one of those that gets sent in, then the community paramedic gets a text notification to check in on that patient. And then they also do care coordination. In clinics, or taking patients to clinic, paramedics can do treatments in the clinic. Oftentimes they're a partner in providing flu shots and now with COVID-19 shots. Also doing risk assessments, case finding and referring to primary care. If an ambulance finds a patient that does not have a primary care physician, then they can be referred to one. They're part of the medication management team. So one of the first things community paramedics do when they respond to a patient is go through their medication inventory, make sure that all the prescriptions that have been written have been filled and that the patient understands why they're taking them, and then has a method for getting refills. Health promotion clinics are a big part of most community paramedic programs. For example, if there's a senior center in town, the community paramedics will go in on the third Saturday or something like that, and anyone can come and go through a health assessment. Sometimes that includes some other kind of monitoring, like checking their blood sugar, that sort of a thing. And they can get some health promotion, talk to a paramedic about what their chronic care needs are. And then, of course, partnerships are the way that all works together. In-home care, I've already mentioned some of the things that they do, the point of care testing. If you're familiar with iStat, it's a blood analyzer machine that's portable. Lots of community paramedic programs use that and are doing blood values at the scene in the patient's home rather than having them go to the clinic to have that done. Medication administration, if we're following a patient that has congestive heart failure and their legs are swelling up, we have the ability to give them medication to take care of that and then monitor them for some period of time after doing it. And we can hopefully avoid a trip to the emergency room because of that. Intravenous therapy, remote monitoring, immunization, assessment, and diagnostics. Let me stop there and see if Mike has connected yet.
I think no. He's
okay. All right. I'll continue then if that's okay. This is a model of what their community paramedicine looks like. I'm not sure what all of these acronyms are, but they conduct wellness clinics. They are connected to palliative care, point of care testing, and some of those other ones I don't know what they stand for. I'm sorry about that. So why use a community paramedic? As I mentioned early on, paramedics have a really broad scope of practice and skills that they're able to do. And we're simply taking the things that they already do and having them use them in a primary care, public health, or specialty care environment. That doesn't just translate easily. There is a necessary amount of education. The most common course is our community paramedic clinician course that I showed on a previous slide. That's about 14 college credits. And so there's a core set of knowledge that the paramedic needs to have that isn't part of their emergency training. Those include the social determinants of health and other areas like that. So everybody gets a core set of training. That's usually about 100 hours. Then they have 200 hours of time where they spend in different clinical environments. So for example, if a community paramedic is going to use one of those blood analyzers, they'll spend clinical time in a lab so they can interact with the lab people and understand what their procedures are for the way that they prep, the way that they draw, the way that they store. We want the community paramedic to do things the way the lab does and make sure that they're able to test the blood if it's brought back to the lab because their accreditation requires it to be done a specific way. So that also might, if they're going to do something with cardiology, that would require them to spend some number of hours with a cardiologist. Usually they are doing immunizations, and so they'll spend time most often in a public health environment. And to complete the course, they'll be required to give 50 flu shots or something in that arena. So while the didactic portion is consistent to make sure that everybody has the same baseline of training, the clinical part of the class is tailored to the specific things that they're going to do in their community. Every community is different. If you're in a town with a hospital versus in a town that doesn't have a hospital, what is available and what you need the community paramedic to do is different. If you're in a town that has a clinic versus being 60 miles or 100 kilometers from the closest clinic, again, the available resources is different. And so the really cool thing about community paramedicine programs is that they're tailored to the specific needs of the community. And what the paramedics do is tailored to the specific shortfalls or access barriers in that community. And so Renfrew has geographically spaced out the 5 FTEs of community paramedics that they have on every day, and they're also available around the clock. So the vision of the paramedicine program in Renfrew is to improve the quality of life of the residents and visitors of the county. The paramedic service upholds the values of trust, quality, and empathy throughout the provision of services that are responsive, appropriate, reliable, and safe. And so the goal of community paramedicine is to give the right care to the right patient at the right time, in the right place, and the first time. One of the things that happens often is we will deal with behavioral health patients, and they have some sort of issue that requires that they can't be left at home. And so what will happen in the traditional environment is they'll be taken to the emergency department, they'll be evaluated, they'll sit there for a few hours, then someone will try to find them a health and a behavioral health facility that's appropriate. Then they get another ambulance transfer, and nothing's happening the first time. And so one of the goals with community paramedicine, if behavioral health is an issue, is to have a pathway created so the paramedic can transport them directly to the behavioral health facility and bypass the emergency department. In terms of what they do, case finding occurs through emergency calls where other paramedics identify a patient that could benefit from a community paramedic program. Um, it might be referrals coming in from a clinic. So, for example, if a physician is following a patient and they know that they're vulnerable and they miss an appointment, sometimes they'll make a referral and ask the community paramedics to go to the home and make sure they're okay, and might specify something specific that they want done. The community paramedicine program identifies and refers vulnerable populations to match services. Community paramedics are paramedics. They're not dialysis technicians. They're not nurses. They're not nurse practitioners. Can't do radiology. So we recognize what our limitations are and make sure that we're able to match a patient to the service that they need. And then one of the goals is to do a community-based assessment that involves, so when you design a community paramedic, what you do is go find out where the access barriers are, where the care gaps are, where the availability of services are absent, and you build your community paramedic program around those shortfalls. We also do patient education. Oftentimes, when someone gets discharged from a hospital, even for something that might seem routine, and the nurse is going through the discharge orders, the patient is focused on their pain at that time, or they're looking forward to get home. And while they hear the instructions, they don't necessarily understand the instructions. So one of the roles that we do is to make sure that the patients understand the information that they were given at discharge at a time that's after the actual time of discharge. Testing, treatment of advocacy, and the overall goal then is to improve the quality of life. Renfrew has a toll-free number. It's an 844 number. It's monitored 24 hours a day. Its goal is to decrease unnecessary calls into the emergency system. The stakeholders have a consistent number that they can use to contact the community paramedics. So if a nursing home has a patient a community paramedic is following, they use the same number for that. And patients also can access that phone number and then speak directly to a community paramedic, which can give them an alternative point of care rather than through the emergency system. Okay, can I check and see if Mike has joined? We're into his specifics now.
Maybe he's not a giant, and you have actually 2 minutes of time. So time is over. You can
Okay.
continue for 2 minutes.
Okay, I'll finish. I think we're just about finished. So I wish I could do a little bit better job with this because of the topic area that you're covering, but I also hope you can take what I've covered so far and think about how community paramedics might work in your palliative care program. There's a lot of things that they can do. They are excellent assessors of patients that are in crisis. People welcome us into their home on the worst day of their life, and there's just a lot of positive things. And community paramedic programs again are filling gaps. So we're getting into all kinds of areas we never envisioned they would be in back in 2005 when this movement started. And palliative care is one of those where we need to be, and Renfrew is doing it. So they have one of the ways that they're managing COVID up there is having the community paramedics do testing. We don't have much of that going on in the States. There are some isolated places where it's happening, but Canada is using the community paramedics to do that. I also suspect that Canada will use paramedics to deliver the vaccine as the primary source of delivering the vaccine when it becomes available there. They have a history of doing that. In fact, in where Mike is in Ontario, every fall, the health department posts billboards that say, if you think you have the flu, don't go to the hospital, call the community paramedic. And so the community paramedics are the major deliverer of the flu vaccine in Ontario, and also trying to go to the patient's home, figure out whether or not they do or don't have the flu, and then deciding if they do, which ones actually need to occupy hospital beds and which ones don't. That way we can keep the emergency departments a little bit more free. I don't know the acronym SMK, so I can't address that on Mike's slide. We're already being called to this. If you're in a rural town, oftentimes the paramedic is the only healthcare provider. And so we know that people that live in small towns call the paramedic on the phone and say, hey, I've got this symptom. What do you think? Should I call 911 or not? So we're already being called, but historically it's with somewhat limited resources and, quite frankly, limited training, because we didn't have community paramedic training education available until 2007. I'm not quite sure what that last bullet point means, so I'm going to skip over it. I don't want to do that. But this is what community paramedics programs are a lot like Swiss cheese. We're trying to fill the holes, and the holes are different in every town. So in terms of palliative team support, we need to be part of the team, and this is a graphic that shows what it's like if we're not, and what it's like if we are. And again, it's the right side of that connection where we want our community paramedics to be in everything that they do. We have had a twist with COVID-19 that has accelerated some changes in the states here. It's made some things possible that wouldn't have previously been possible. One of the major ones that community paramedics are taking advantage of is the expansion of the availability and ability to use telehealth. We're finding that a very useful tool, whether it be community paramedic to social worker, community paramedic to emergency physician, community paramedic to home care. The second wave is here, but telemedicine and other things that have sprung up because of COVID are actually turning out to be good for us in terms of the way that we're able to integrate into the system and make it more efficient. So a couple of things that are important for us in terms of being a partner with palliative care is that everybody understands the capability of the community paramedic, so that we can do the right things and the things that we're capable of doing, and that we know how to get a patient somewhere else if they need some capability we're not. So how to refer, sometimes we have clinics that will set up a special phone line for us so that the clinic will see a patient when there's no appointments available. They'll work them in. That's a pathway that's important. We need to understand the medical directives that the palliative care providers have attached to the specific patient, how we're going to do documentation, whether that's on paper or electronic, or if we're capable of being in the other healthcare providers' medical record system, and how follow-up is done between the community paramedic and the other parts of the palliative care team. Sometimes we have system management kits that are either in the community paramedics vehicle or at the home where the community paramedic bench. Hold on a second. He just knocked over my Christmas tree. Let me get him out again. Come.
I think we're over time anyhow.
Yeah.
So
Okay.
maybe we should stop. Just, I know there were one or two questions, and then because we're already over time.
Okay. Very good.
So we have a question from Dr. Sinu. So that what are the service rendered by the paramedics in the community, and what is their qualification?
Could you say that one more time?
So what are the service rendered by the paramedics in the community, and what is their qualification?
Their qualifications vary depending on what country you're in. In the United States, we have 3 levels of paramedics. The basic level is called EMT. The intermediate level is called advanced EMT, and the advanced level is called paramedic. And so the qualifications that they have vary by those levels. Basic level provider, for example, doesn't give drugs and doesn't inject medications or do a medication drip, where the advanced paramedic does. The community paramedic education system that most of the world has adopted is the course that we created, and it's 14 college credits, or roughly 300 hours. And so it adds the components of public health, primary care, and specialty care.
Thank you, Dr. Gary. So I hope Dr. Sinu got the answer. Thank you. So as we'll move ahead with our next presentation.
Okay, great. Thank you.
Just for 1 minute, Gary, one of the things I would, good presentation. One of the things I would suggest in the States, if you really, not only in the States, but here where we worry in hospices about people going to ERs, a good study would be, can you, being part of a hospice, decrease ER visits?
Yeah, so hospice and home care are 2 areas where community paramedic partnerships thrive.
Okay.
There are hospice agencies that contract with community paramedic programs, and that contract includes penalties. That includes a goal and actual financial penalties if that goal isn't met. So oftentimes, our job is to take someone who's gone into crisis with hospice, and because of the emotions at the time, is wondering about their do not resuscitate order, or the family wants to rescind the do not resuscitate order. And so a lot of those arrangements have to do with dealing with those patients at that specific time. And the goal is to bring everybody calm and to make the right decision. So yes, very good point.
Yeah, but my thought would be to research it, I think if it were researched and actually proven that this saved ER visits and clearly then saved costs, Medicare guidelines may even be changed then to include, so you need to actually research it.
Yep, got it. Thank you.